Hello friends, today we are going to discuss this question which was asking DRNB critical care exam in 2020. The question was new guidelines for mechanical thrombectomy in acute ischemic stroke. So these are the recommendation from the AHA stroke guidelines. So for patient who otherwise meet the criteria for mechanical thrombectomy, non-invasive vessel imaging of the intracranial arteries is recommended during initial imaging evaluation. For patient with suspected large vessel obstruction who have not had non-invasive imaging as a part of their initial assessment for stroke, non-invasive vessel imaging should be obtained as quickly as possible. So both of these treatment has a class of recommendation 1 level of evidence A. In patient with suspected intracranial large vessel obstruction and no history of renal impairment, who otherwise meet the criteria for mechanical thrombectomy, it is reasonable to proceed with CT angio if indicated before obtaining serum creatinine concentration. In patients who are potential candidate for mechanical thrombectomy, imaging of extracranial carotid and vertebral arteries, in addition to intracranial circulation, may be reasonable to provide useful information on patient eligibility and endovascular procedure planning. Then it may be reasonable to incorporate collateral flow status into clinical decision making in some candidate to determine eligibility for mechanical thrombectomy. When selecting patient with acute ischemic stroke within 6 to 24 hours from last normal who have left large vessel occlusion in anterior circulation, obtain CTP or diffusion weighted MRI with or without MRI perfusion is recommended to aid in patient selection for mechanical thrombectomy, but only when patient meet other eligibility criteria from one of the RCTs that showed benefit from mechanical thrombectomy in this extended time window. Then how to select criteria. So selection of the criteria is based on the down trial and the diffuse trial. So eligibility criteria according to the down trial is if patient presented within the 6 to 24 hours, if occlusion location is the intracranial IC or proximal MCA, if age is more than 80 and NIHS is more than or equal to 10, then infarct core size should be less than 21. If age is less than 10 and NIHS score is more than or equal to 10, then the core infarct volume should be equal to 31 ml. If age is less than 80 and NIHS is more than or equal to 20, then core infarct volume should be between 31 to 50. So imaging selection is the CT or MRI rapid software. According to the diffuse criteria, the eligibility is between 6 to 16 hours, and occlusion location is the extra or intracranial IC or proximal MC. The infarct volume is less than 70 ml, and the mismatch ratio between the infarct core and penumbra is more than 1.8. So these are the clinical trials which were published in context of the anterior stroke, that is Mr. Clean trial, Revascat trial, Escape trial, Swift Prime trial, and Extend 1A trial. Then regarding posterior circulation large stroke, basilar artery occlusion accounts for approximately 1% of all ischemic stroke and about 10% of stroke due to intracranial large vessel occlusion. Although this condition may be relatively uncommon, it captures our attention due to its potentially devastating consequences, which may include death and Longman syndrome. Despite report of the high morbidity and mortality, the natural history can be quite variable, and clinical outcome likely depend on the variety of patient factors such as age, baseline health, severity of the presenting symptom, location of occlusion along the basilar artery, presence of collateral territory of associated ischemic injury. So these are the trial which were published in the context of posterior artery stroke, that is basic trial, base trial, attention trial, and voucher trial. So recommendation are in patient with the acute basilar artery occlusion who meet the criteria from Bauchio and the attention trial, that is NIHS more than or equal to 6, posterior circulatory aspect more than or equal to 6, CT angio with basilar artery occlusion and age is between 18 to 89. Thrombectomy is recurrent indicated within 12 hours of last known vein. In patient with the acute basilar artery occlusion who presents between 12 to 24 hours from last known well and NIHS score more than or equal to 6 and the aspect score is more than or equal to 6, thrombectomy is reasonable. Class of recommendation 2A, level of evidence B. In patient with the acute basilar artery occlusion who present beyond 24 hours from last known well, and if the NHHS score is more than 6 and PC aspect score is more than or equal to 6, it may be reasonable to consider thrombectomy on case by case basis. In age 89 years presenting with the acute basilar artery occlusion, it is reasonable to consider thrombectomy on case by case basis. Thank you guys.